Hello and good day. Today we'll be talking about neurodevelopmental disorders and the changes in the current DSM-5 from the DSM-4 DR. Just a bit of a background of the DSM neurodevelopmental disorders. These are disorders that show themselves early in life often and they persist as the person grows older. So the term childhood disorder may be misleading. And because the development of the disorders in this group are all presumed to be neurologically based, the DSM 5 categorizes them as neurodevelopmental disorders as the new name under the DSM 5. And in this lesson, we will be covering those disorders that are revealed in a clinically significant way during a child's developing years and are often concerning to the families and also with the educators. And remember, however, that these difficulties often persist through adulthood and are typically lifelong problems, not problems unique to children. Now, the neurodevelopmental disorders are a group of conditions with onset in the developmental period, meaning to say, these problems are likely to be noticed and observed right before the child goes or reaches the age 5 years. These disorders likely manifest early in the development, often before the child enters grade school, and are characterized by the developmental deficits that produce impairments of personal, social, academic, or occupational functioning. Now, we would also understand that neurodevelopmental disorders also has or have high comorbidity, meaning to say there could be certain problems that coexist with the given diagnosis of a certain neurodevelopmental disorder. So just like, for example, when a person or a child would be diagnosed with ADHD, there could be a possible existence of a language disorder or also intellectual disability. Now, the symptoms are likely to be apparent prior to the start of schooling, and it likely requires extensive consults with multidisciplinary team, meaning there are a lot of professionals that are involved in the diagnosis, and we need to also consider the opinions or the clinical judgments of these professionals. Just like, for example, the psychiatrists, the occupational therapists, speech language pathologists, the physician, and also the developmental psychologists. Now let's talk about the first disorder on the list under neurodevelopmental disorder. It is called intellectual disability. Under DSM-4 TR, this disorder was formerly known as mental retardation. But now in the DSM-5, it is now called intellectual developmental disability as its full name. Now, talking about the intellectual disability as a disorder in the DSM-5, the practitioners are or have moved away from relying exclusively on IQ scores, and they are now moving towards additional measures of adaptive functioning. So before, in the DSM-4 TR criteria, they were only relying on the IQ score of 70 below. And when a child could score or have that score, then the person or the individual could likely be diagnosed with mental retardation or intellectual developmental disability. Now, with the new criteria added and recommended, we could understand that IQ scores from the IQ testing are considered still, plus the adaptive functioning of the individual. And when you talk about adaptive functioning, it is about the personal independence of the individual and also social responsibility. So at the individual's age, there are expected initiatives, behaviors, and also developmental milestones to be achieved. Now, talking about personal independence, how free is the person to also initiate and execute plans, to make judgments, and also talking about social responsibility, how free is the person to also interact with um, who are of the same age as he is or she is, with the understanding that we are incorporating the intellectual functioning and also the adaptive functioning now under DSM 5. We now have the knowledge that we need to look into the intellectual functioning of the individual and also the individual's adaptive functioning as the principal symptoms for the diagnosis of intellectual disability. Before, it used to be diagnosed as mild and severe only back in the DSM 4, and the same with the DSM 4 TR. Now, severity could also be indicated through these categories, such as mild, moderate, severe, and also profound. Now, if we refer to our DSM 5, the principal symptom, which is under criterion A, the DSM mentions about the deficits in intellectual functions or general mental ability, such as reasoning, meaning the child or the individual may have a difficulty in trying to explain a certain scenario or a certain experience. Another mental ability is problem solving, planning, abstract thinking. When we talk about abstract thinking, meaning to say they could not be able to learn as to how to utilize what they have learned from the real environment, like concepts from the real environment, and apply it in the real world. So let's say, for example, they can't learn the words freedom or values, and especially when application would be done, then they basically don't know how to apply these concepts that they have previously learned. There are also deficits in the judgment ability, academic learning, so they can't learn from instruction, and also learning from their personal experience. So they are bound to also repeat the same mistake that they have committed. Now, these deficits would likely be confirmed by both clinical assessment, meaning there is an interview and a battery of tests, and including the individualized standardized intelligence testing, just to confirm that the individual's general mental ability or the said deficits with the person's general mental ability are present. And because of the deficits in the mental ability of the person, it would likely result for the individual to also have some impairments in his or her adaptive functioning, such that individual fails to meet standards of personal independence and social responsibility in one or more aspects of daily life, including communication, social participation, academic or occupational functioning, and personal independence at home or in community settings. Now, the DSM has further identified deficits in adaptive functioning through three particular dimensions. The first mentioned dimension is the conceptual dimension or domain. Now, the conceptual domain specifically identifies the skill deficits in areas such as language, reasoning, knowledge, and memory. When we talk about the social dimension or domain, it also talks about the problems with social judgment and the ability to make and retain friendships. And lastly, the practical domain is about the difficulties in managing personal care, such as hygiene or maintaining hygiene or job responsibilities. And when you check your DSM 5, all three domains are present and described thoroughly so as to help us determine the severity of the intellectual disability problem. So as you can see, you could also be able to refer to the DSM-5 and be able to take note of the several descriptors and conditions being laid upon for the clinician to make a clinical judgment as to the level of severity of the intellectual disability of the person pertaining to these three domains, which are again the conceptual, social, and practical domains. Now, the deficits in adaptive functioning is met when at least one domain of adaptive functioning requires ongoing support for the person to perform adequately in one or more life settings. So, either of the three, even if it's only one particular domain that may also need ongoing support for the person to perform in an adequate level, then such deficit might be a confirming symptom for us to diagnose that individual's intellectual disability, which could be present at home, in school, or even in occupational settings. And criterion B for intellectual disability tells us that the person has deficits in adaptive functioning for personal independence and social responsibility, may it be related to communication, social participation, and also independent living. And it could also be in across multiple environments that needs only one particular setting. As mentioned, it could be either at home, school, work, or in the community. And to emphasize further, we also need one particular area in the deficit in adaptive functioning, which is criterion B. May it be either communication, social participation, or independent living. So these are added symptoms that could also help us identify further that the person may likely be suffering from intellectual disability. And just to also show the changes that were brought in the DSM 5, which is the current version of the DSM, back in the DSM 4 TR, the only reference as to the person could be diagnosed for intellectual disability or mental retardation back in this version was that there should be a significantly sub-average intellectual functioning of about IQ equal to 70 or below. And based on the intelligence quotients, they are to diagnose the severity of the intellectual disability or mental retardation according to these categories. So we have mild mental retardation if IQ level is at 50 to 55 to approximately 70. Moderate mental retardation would also be diagnosed if the IQ level of the person is at 35 to 40 to 50 to 55. Severe mental retardation would likely be diagnosed with the individual having IQ level at 20 to 25 to 35 to 40. And profound mental retardation would be diagnosed if the IQ level is at 20 or 25. Now, mental retardation could also be unspecified when it comes to severity, when there is also strong presumption, but the condition warrants untestable psychological functioning, which could tell us that it is impossible for us to assess the person's intellectual functioning due to some physical deficiencies such as blindness and other related difficulties. Now, moving forward, the diagnostic assessments must determine whether improved adaptive skills are the result of a stable, generalized new skill acquisition, in which case we would somehow be telling ourselves that the diagnosis for intellectual disability as a clinician may no longer be appropriate because the person's general mental ability or intellectual functioning and adaptive ability has improved, meaning we could no longer be diagnosing the person with intellectual disability. Meaning, in this case, the diagnosis of intellectual disability is now ruled out. However, if the improvement is contingent on the presence of supports and ongoing interventions, meaning there is that clear manifestation of improvements based on the ongoing interventions by a clinician and other related professionals working together for the intervention of the said mental disorder, then still the diagnosis of the intellectual disability would be ruled in. So still, the person would be considered to be diagnosed under or to be diagnosed with intellectual disability. Now, moving forward with global developmental delay, the diagnosis for such mental disorder is reserved for individuals under 5 years old when the clinical severity cannot be reliably assessed during early childhood. The diagnosis is given when an individual fails to meet expected developmental milestones in several areas of intellectual functioning previously mentioned, and they cannot be assessed. Okay, it also applies to individuals who are unable to undergo systematic assessments of intellectual functioning or too young to participate in the standardized testing, just as long as they are under 5 years old. And there could be some challenges where we cannot be able to administer tests, and we could not also interview the individual solely because of the individual's age. Then the diagnosis of global developmental delay would also be ruled in, provided that there is clinical significance in relation to intellectual functioning and also adaptive ability. Now, with patients who are over the age of 5 years and assessment of the degree of the intellectual disability by means of locally available procedure is rendered to be difficult, just like what was previously presented, due to some physical impairments or deficiencies may be related to sensory impairments or physical impairments such as blindness or locomotor disabilities, then we would be diagnosing our patient with unspecified intellectual disability so long as they are over the age of 5 years. And this is used in exceptional circumstances and likely requires reassessment after a period of time, which would likely tell us that the diagnosis for the unspecified intellectual disability would likely be a working diagnosis or a provisional diagnosis, which would likely lead us to the understanding that we need to do a follow-up as a clinician, and we need to have a principal diagnosis once there is an opportunity for us to reassess our patient's case.